So thank you for inviting me to share some cardiac MR and CT cases with you. This is, I think, an exciting time in your training, studying for the boards. I remember a few years ago when I was in your situation, I felt like I was smarter than I ever was at any other point in my career. And I'm sure you will all feel the same way in a few weeks right before you take your exam. And so, the cases that I will be showing today, I try to represent the various areas that are in the ABR blueprint. And just as a reminder, your cardiac cases will include valvular disease, pericardial disease, myocardial disease, great vessels, so aorta, pulmonary arteries, coronary arteries, cardiac tumors and masses, congenital, but it also includes, it might include questions that you might more commonly associate with the chest section or chest radiographs, because there'll be questions about devices, lines, tubes. There will be some physics questions, as well as quality and safety. And then don't forget that some of your pediatric score will also include some cardiovascular questions. And so the cases that we'll go through today will cover a lot of these different areas, if not all of them. And so we'll jump right in. This was very important back when we had live in-person hot seat oral board exams. If they gave you some clinical information, you really had to pay attention to it. And that's still the case, I think, to today with written exams. If they give you some information, it's important, pay attention. And then after you've been board certified and you're working as a board certified radiologist, the clinical information is going to be very, very helpful when it comes time to putting together your impression, putting together a nice, succinct differential diagnosis. Gone are the days when you had to say clinical correlation is recommended. All of the clinical information is now at your fingertips in the electronic medical record. And so I strongly, strongly encourage you to look at all of the clinical information that's provided to you. So we'll get started. The first case, 53-year-old female with substernal chest pain. She has dyspnea, lightheadedness. Her troponins are negative. She has a history of hyperlipidemia and a sister with early coronary artery disease. And so this first slide here, sort of a simple physics question. This is the ECG tracing snapshot that comes across, and the question is this prospectively triggered or a retrospectively gated acquisition?
Okay. So I see where the triggering is happening just before the QRS complexes. So I would say this is prospective gating. I haven't read all of these, but
yeah, exactly. So this is a prospectively triggered acquisition, and we'll kind of show over the next couple slides some of the differences between prospective triggering and retrospective gating. And so with prospective triggering, the CT scanner is monitoring the ECG signal it recognizes the peak in the R wave, and it's monitoring this, even before you start your scan. So it's sensing what's your average heart rate, and then when it comes time to actually start your scan, um, it is going to be monitoring them in real time. And when it detects a peak in the R wave, it then will go out a predefined amount of time and start the acquisition when you tell it to. In most cases, we are acquiring the data during diastole when cardiac motion is minimized. Um, the scanner will be on for a fraction of the R wave, or of the R to R interval, and then the X-ray beam turns off, and you then move into the next position. Your scanner detects the next R wave, and it turns on again. Usually for a diastolic acquisition, it's going to be on from about 50 to 60% is when it starts, and then it turns off at about 80 to 85. Now, depending on the type of CT scanner that you have and the amount that that you need to cover in your acquisition, it might require multiple rotations to complete your scan. Or if you have a 256 slice CT scanner or a 320 slice scanner, and you're just covering the heart, you might be able to scan the entire heart in a single rotation. And if the patient has some heart rate variability, or if their heart rate is a little bit higher, we might want to open up our acquisition to include a little bit of systole as well. When your heart rate is typically, if your heart rate is above 70 or 75 beats per minute, the end of systole may give you better image quality. And so in that situation, we can just open up our acquisition window a little bit to include end systole, in addition to most of diastole. Now, in retrospective gating, the X-ray tube is on throughout the cardiac cycle. As the X-ray tube is spinning around the chest, we are acquiring both X-ray data to get our CT images, and we're also recording the ECG signal. And the scanner is able to register both the ECG signal and the X-ray detection, and it will bin the data after the scan has completed, so that you can then reconstruct images from any phase of the cardiac cycle. In this example here, if the y-axis is your MA, it's sort of a consistent MA throughout the acquisition. Or if you want to decrease your dose, you can reduce the MA during systole when the heart is moving most rapidly, and then ramp up your X-ray current during diastole. Okay, so I hope that that's a very quick overview of how we would perform prospective triggering and retrospective gating. You might see a question related to that in the cardiac portion of your exam. All right, so we can either continue with you, Hazel. This is the same case, or we can move to the next volunteer.
Yeah, I guess we can each do two questions. So
Okay,
I can do
sure.
this one, and then
Okay.
we'll move on. So this would be the right coronary artery coming off the right coronary cusp.
Exactly. And so one of the things that I always go through with the first year radiology residents and really try to emphasize to them is that radiology, it's really all about anatomy. and learning and going back to your first year of medical school, figuring out, where the normal anatomical structures are located. And so if you really understand anatomy, you're going to be a very, very good radiologist. And I think it's one of the reasons why a lot of the questions that are going to be on your board exam are going to be anatomical questions. And they might not always ask you to identify the anatomical structure on, a conventional orientation. So it might not always be a straight axial slice. It might be a sagittal image. It might be coronal or even obliquely oriented. And there'll be a few questions here today that kind of ask you to identify normal anatomical structures. Okay, so here's the next question.
All right, so the next case or question taker for today is San from VCU.
Hi.
Hi, Son.
Hi. So we look at the LAD as label. Is there a disease? I think this is like myocardial bridge. I'm not sure. Is it? I don't see any cows, but
Yeah, so this is a pretty straightforward, simple question. This is these are reformatted images from a coronary CTA. This is a multiplanar reformatted image up on the top, a curved planar reformatted image here on the right, where we kind of stretch out the vessel into a sort of a straight line in a single plane. And then we have a volume rendered image down here in the bottom left. And this is a normal looking coronary artery. We do not see any non-calcified plaque or calcified plaque. There's, as you pointed out, there might be a short segment of myocardial bridging here in the middle to distal left anterior descending artery. So in general, like if you were reading this overnight on call, you would call this negative. Okay. And what about the circumflex? Is there any disease in the circumflex artery?
I don't see any cows, but like a little outpouching in the proximal.
Mm-hmm.
Is that
this
overcall or?
Yeah, so you see this little bump here. That could be where I think that's where the left anterior descending artery branch is coming off. And then it just kind of goes out into a different plane. So again, the answer to this question is no. There's no coronary artery disease there. What about the right coronary artery?
Yeah, I don't see anything.
Okay, I agree. And then, this question, here's another question related to this specific image. We can maybe have the next question taker take this question.
Sure, that's me. Thanks, San.
Okay, so Kate, the question is, you see this line right there, and there's another one right there. What do you think? And there's another one up there.
Yeah, so I think we call them like stair step artifact, from where with each in the perspective gating, they'll take different slices each heartbeat. So I think that's what that is from.
Yeah, exactly. So you see this little step off. You see it best, I think, up here near the top in the aortic root. There's a little stair step in the aortic root. And as you indicated correctly, this is from a prospectively gated acquisition. And there's just a little bit of variability in the RR interval. So a little bit of variability in the position of the aortic root or the coronary artery from one rotation to the next. And that stair step artifact is going to be more pronounced the higher the heart rate, the more irregular the rhythm is. In some times it can be quite distracting. And so as a follow-up, I would say, so what would we do to try and minimize this artifact?
So in patient selection, I guess you can not pick or pick someone, I guess, who has more of a regular rate. I know that we will generally treat our patients with beta blocker, like metoprolol, I think, or something beforehand to get their rates really low. And then encourage the patient to not move, especially also during that exam.
Yeah, exactly. So heart rate control is very important to get really good quality coronary CTAs. In general, we try to lower their heart rate below 70, depending on the scanner that you have. And it might be 65, it might be 70. But basically, you want to give, most often you'll give beta blockers. If they have a contraindication to beta blockers, you could try calcium channel blockers. And so something to brush up on between now and the exam would be some of the contraindications for beta blockers. So, somebody who has has a history of asthma, for example, or really bad COPD, beta blockers would be contraindicated. And so in those situations, you would consider giving a calcium channel blocker, okay? And then this is not a question, this is just, and again, I don't know that you're gonna have a question about CAD-RADS on the board exam. For those of you that do not do much coronary CTA, just spend 5 minutes looking at the CAD-RAD scoring system. It's very similar to BI-RADS, LI-RADS, PI-RADS. Basically, it goes from 0 to 5. 0 is normal, 5 is occluded, and then there's various degrees between 0 and 100% stenosis, okay? And the the scoring is really, it's just based on the degree of stenosis, and it's the maximum stenosis in all vessels. So if you have one vessel with a 90% stenosis, that's going to be a CAD-RADS 4. Okay, next case.
Sorry, I just had a question
Yes.
in the chat. Is the stair step artifact only in prospective gating?
No, you can also see that stair step artifact in retrospective gating with your reconstruction. And so, so the stair step artifact by itself does not indicate that it's prospectively triggered or retrospectively gated. It's due to misregistration of the position of the cardiovascular structure because of variability in RR from one slice to the next.
Thank you.
All right, so the next case is a 49-year-old female presented to the ED with intermittent chest pain, back pain, shortness of breath, has a history of hypertension, hyperlipidemia, and let me move the video panel down below so I can read. Obesity, social history, she's a smoker, and she has a family history of early coronary artery disease, okay?
So this case, sorry, Amina, this one will go to you. So Amina's an R3 from Stony Brook.
Okay.
Hi there. All right, so you see the left anterior descending. This is the curved multiplanar reformat, and there's the calcified plaque at the proximal LED, yep, right there. And then just distal to that there's non-calcified plaque that's causing a pretty significant stenosis. And if that's greater than 70%, that's probably the source of her ischemic symptoms and would warrant coronary intervention.
Yeah, exactly. So, this is a young woman who came into the ED, and as you pointed out correctly, has calcified plaque proximally, and then just beyond that, there is a non-calcified plaque that's causing significant stenosis, particularly when you look at these curved planar reformatted images. Definitely greater than 50%, and in some of these views, you might get the sense that it could be close to 70%, if not more. And so this is somebody that you definitely would want to investigate further. You would not discharge this patient quite yet. Usually when they are in the ED in this situation, they will then consult cardiology. Definitely you would want to monitor their ECG, their troponins. If they subsequently rule in for a STEMI, you then go down the STEMI route. But if they don't, if they remain sort of as a non-STEMI or unstable angina, you then kind of go down that pathway for management. Okay, so here's the next case, somebody who presented with chest pain. And
Okay. So which vessels are the LAD, circumflex, and RCA? All right. So see that. Okay, so I know the LAD runs in the interventricular septum. So I think that's A. And then going around more laterally would be the circumflex, so that's B. And then going inferiorly would be the RCA. So I think that's C.
Yeah, so this is a tough case because this is a patient who has anomalous coronary artery origins, and not just one anomalous origin, but two anomalous origins. And so, and this is probably a case that would be, if they were giving it to you in the board exam, you might be able to scroll up and down the axial images. But for these kinds of board reviews, it's a little bit difficult to have that interaction. So anyhow, these are both volume rendered images, surface shaded images. The image on the left, we're kind of looking at the front of the heart. So you have the ascending aorta right here, the main pulmonary artery right there. And this is an atrial appendage. Is this the right atrial appendage or the left atrial appendage?
So the left atrial appendage is associated with the left ventricle. I would say that that's the left atrial appendage. It's closer to the aorta. Not exactly sure.
Yeah, so we're looking straight to the front. So this is like a straight AP view. So this is going to be the right atrium. And then the left atrial appendage is over here on the left. Here's the apex of the heart over here. And so we have the right atrium, and then the right ventricle is right here. So which vessel is that going to be?
The RCA?
Correct, yes.
Okay.
And so if you're thinking about like when you're looking at a chest X-ray, the apex of the heart is always on the left, and then the ascending aorta is going to come out laterally towards the right. And then on the left side of the heart, you have the left pulmonary artery. Below the left pulmonary artery is the left atrial appendage, just lateral to the main pulmonary artery. Okay, so if this is the right coronary artery, we have the right ventricle here and the left ventricle over here. So as you go down this groove, that's the anterior interventricular groove.
Yes.
Which coronary artery is B going to be?
That's the LED.
Correct, yep. And then that's going to make C.
The circumflex.
Yeah, so when we're looking down from down below, this is the right coronary sinus, and all three coronary arteries are coming off of the same sinus of Valsalva. And in this particular case, we have the circumflex coming behind the aortic root, and the LAD going anteriorly, going in front of the main pulmonary artery. And so, do you think that this is the cause of her chest pain? In other words, do you would this be considered a quote unquote malignant anomalous coronary artery course?
No, so if it's the only one that's malignant is interarterial. If it's like retroaortic or prepulmonic, those are usually not symptomatic.
Yeah, exactly. Good.
Thank you.
Here's the the
Oh,
next case presented with chest pain.
Right, so thanks, Amina. The next case taker is Taha from Case Western.
Okay, so we have axial CTs through the heart. So I see the takeoff of the LAD. I guess maybe the RCA might be arising from the left coronary cusp. Yeah, I see it there now. Okay. So this would be surgical management if the patient's symptomatic. Otherwise, you just watch the patient.
Yeah, so this is another example of an anomalous origin and course. In this case, it's the right coronary artery that is arising from the left main coronary artery. And you can see it has a very, it follows the course of the aortic root in cross section. It is narrowed in the AP direction. And so both of these findings would suggest that it has an intramural course, that it's in the wall of the aorta for a short distance. Our understanding of how to manage these patients is sort of evolving. And as you correctly pointed out, right now, if the patient does have symptoms, of angina that can be attributed or that sound like ischemia, they would treat these surgically. These can either be unroofed, where they open up the inside of the aorta and kind of open up this membrane like that, or they could do a reimplantation, where they kind of cut the right coronary artery and then just reinsert it on the right sinus. Okay, next case is a 42-year-old with chest pain.
Okay, so we have a CT showing I think that's the right ventricular outflow tract, but I'm not sure.
Yeah.
Okay. So I think the artery in the front, it looks like that might be the RCA.
Okay.
And it looks like they have like a common branch, maybe. I don't know if this is also anomalous origin, but
Yeah, so which vessel do you think this is? Right here.
it could be the left main.
Mhm.
That could be going retro aortic.
So this would be the pulmonary artery right here. If this is right
Oh,
ventricular.
pre-pulmonic, sorry.
Right. So this is the sternum is up here,
Okay.
RVOT, pulmonary artery. So this vessel, it's not going in front of the pulmonary artery, like we saw in the earlier case. This vessel is going right between the aortic root and the main pulmonary
Oh.
artery.
Okay, so intra-arterial
Yep.
course.
Yeah, so this is another interarterial course. But in this case, rather, it's the left main that is going between the aorta and main pulmonary artery. And again, this is the kind of anomalous coronary artery course that you would be concerned about. You would definitely want to investigate this further. And most of these are going to be treated. This would be considered malignant. Okay, next case
All right, thanks,
is,
Scott. Oh, sorry. The
Yep,
next case
thank you.
taker will be Josie from UIC.
Okay,
Yeah, and I just got just got a question in the chat.
sure.
How can we differentiate between interarterial versus subpulmonic course?
Good question. So there are some that will, some of these anomalous coronary, the anomalous lefts that come off and then go, they'll dive down and they'll actually go through, some will go through the septum, and then others might just kind of go along the septum, but not be quite in between the aortic root and the main pulmonary artery. You're going to see that best on a sagittal reformat. And it really just has to do with, how close it is to the, like in this case, and in this previous case, the anomalous coronary artery was going along the sinuses of Valsalva, so along the aortic root. Those would be an interarterial course, whereas if it dove down below, down here, below the aortic root, kind of down by the annulus or even lower, that would be more of a subpulmonic course.
Thank you. All right,
Okay,
Josie, you're up.
Yeah, 42-year-old, intermittent chest pain for 3 months, family history of coronary artery disease, smoker, borderline low HDL, and obese. And so they performed a stress rest SPECT study. And so I guess the first question for you, Josie, is do you see any signs of ischemia on this study?
Let's see. I don't know if I see any perfusional defects. Maybe there is something along the septum, but I feel like it's there at stress and rest.
Mm-hmm.
What's catching my eye is the size of the ventricle looks big. We usually look at these in colors. I'm not used to looking at them in black and white, but I'm not seeing.
Yeah, so this is pretty, again, on the exams, they usually don't show you cases that are really subtle. I think they want you to find the finding fairly quickly and come to a conclusion or an answer fairly quickly so that you can move on to the next case. So this is, this looks normal. It was read as normal, but they were still concerned with the patient's symptoms, particularly given the history. And so then we proceeded with a coronary CTA. Is this normal or abnormal?
Abnormal.
Okay, what do you see?
So I see in the LAD, like just after like the some of the like marginals come off, there's like an area of like focal stenosis with non-calcified plaque.
Yeah, exactly. So we'll step back a little bit. So what are the branches that arise from the LAD, the left anterior descending coronary artery, called?
I think they're the maybe obtuse marginals or diagonals.
Your second answer is correct. So
Okay.
LAD diagonal. Okay, that's the LAD ends with a D, so the branches start with a D, diagonals. And then the obtuse marginals will come off of the LCX or circumflex, and then the acute marginals come off of the RCA. So RCA ends in A, acute marginals that start with A are the branches that come off of the RCA. And then, the letter X has some obtuse angles in it. And so the branches are called obtuse. And that's not really why they're called that, but that's how I remember which branches come off of which. Okay, so LAD diagonal, circumflex, LCX gives you obtuse marginals, and the RCA A gives you acute marginals. And then we'll stick with this K. What about the RCA? Actually, before we move on to that, so as you pointed out correctly, Josie, there is a mixed calcified and non-calcified plaque here in the proximal LAD, just after the first diagonal, causing severe stenosis. Okay, so here's the next question.
All right, so now we're looking at the inline RCA. Proximal course looks pretty good, and then kind of right as it takes its turn there is also some non-calcified plaque.
Yeah, exactly. So here in the distal RCA, non-calcified plaque giving, again, with a severe stenosis. So we have severe multivessel disease in the distal RCA. Okay, who's the next question taker?
Yep,
Case
thanks,
taker.
Josie. Next we have Songman from St. Vincent.
Okay, so this is a 62-year-old outpatient, chest pain with exertion, family history of coronary artery disease, history of smoking, had a SPECT perfusion study that showed a possible fixed defect in the inferior wall versus attenuation artifact. And so we did a coronary CTA. What do you think? Is there coronary artery disease? Yes or no?
Hi, Doug. So the LAD looks okay to me. The LCX also looks okay.
Yeah, exactly. You are correct. This is another example of a normal coronary CTA. This patient does not have coronary artery disease. And so the finding that was seen on the SPECT study was most likely due to attenuation artifact. And here's the next case, 67-year-old, again, another outpatient, atypical chest pain, hypercholesterolemia, had a normal SPECT perfusion study, but they saw 2 millimeters of ST depression on the exercise ECG. And so they asked us to take a closer look at this. Here's an image of the LAD. What do you think?
Yeah, so in the LAD, we see multifocal areas of plaque mostly calcified, but also non-calcified. And also I see areas of positive remodeling somewhere here. Yeah, so significant narrowing, especially at this level, um, and also somewhere, yeah, this calcified plaque here, yeah, but multifocal extensive atherosclerotic changes in the LED.
Yeah, exactly. So we have significant or severe coronary artery disease in the LAD, calcified and non-calcified. Here in the proximal LAD in particular, this is a very worrisome, vulnerable looking plaque with the positive remodeling. Okay.
Sir, I'm sorry,
So
we had
there's
a question in the chat about, can you please explain what imaging features are present in positive remodeling? I don't know if you had a case or something to talk about more specifically later, but that
Oh, no, that's a good question. So positive remodeling just refers to the fact that when you have this atheroma in the vessel, sort of early on, there's a lot of inflammation that is induced in the vessel wall. And so early on, that inflammation will cause the vessel wall to go out. And so if you were to measure the diameter of that vessel from outer wall to outer wall, it would be bigger than normal. And so that's where the positive comes from. And so you'd have this atheromatous plaque that's inflamed and it's bulging out into the epicardial fat before you get any luminal narrowing. Now, in this case, it's a little bit more advanced because we also have luminal stenosis. So the positive remodeling just refers to the fact that you can see the outward bulging of the vessel wall due to the presence of that inflamed atheromatous plaque.
Thank you. I'm sorry, I had one more question that came up. Can you give or point out the very last stenosis that was shown on the previous case? It appears very subtle.
So here's the right coronary artery. The stenosis is here in the distal right coronary artery. So if you follow the lumen of the right coronary artery, all of a sudden down here, distally where it bends, you see focal narrowing of the vessel lumen. And there's this gray non-calcified plaque right there. And you can also see it here in cross section. This is that atheromatous plaque. Kind of looks like a ring where the gray of the vessel wall and the plaque are the ring, and then the enhancing lumen in the center would be the hole in the ring. And this would be a nice example of positive remodeling as well, where it kind of bulges out eccentrically into the epicardial fat. And then this was this was a normal coronary CTA, no disease, and this is severe disease. Okay, so here's the next case.
All right, so the next case taker will be Riley, who's from the Naval Medical Center, Portsmouth.
Hi, sir.
Hi.
Hey, so it looks like we have a single CT image kind of at the level of the cusps of the coronary artery. So it looks like there is a retro-aortic course of the LAD. So again, kind of like we talked about earlier, not a malignant course.
Yeah, this would be exactly. This is an incidental finding. This is nothing that needs to be treated. And it's because of this that I personally do not like to call the posterior cusp the non-coronary cusp. Now, it is perfectly fine to call it a non-coronary cusp, the one that's in the back that in most patients does not have a coronary artery from it. Yeah, to me, it doesn't make sense to say that a coronary artery arises from the non-coronary cusp. So I prefer to call it the posterior cusp. Now, if there's some rotation, some people might get a little bit confused because the posterior cusp might not be truly posterior, but that's a longer discussion. Okay, so next case, another patient with chest pain.
All right. So we're seeing kind of a sagittal and looks like a curved reformat views of looks like the LAD coming down. I do see so I definitely see calcified plaque. I don't know if that's what you're trying to show me here, or if it's just coming up, coming off a little bit more superior than expected.
Yeah, so most of the time the coronary arteries will come off of the sort of the apex of the sinus. Sometimes they'll come up off a little bit high. This one seemed kind of high, very close to the sinotubular junction. Sometimes they can arise above the sinotubular junction, and those are really usually insignificant. But yeah, I think you correctly identified one of the main findings, that there is calcification here in the vessel wall. And this is the left anterior descending artery on the left. This is a kind of like two-chamber view, or a LVOT view of the left ventricle. This is the anterior wall. The inferior wall is over here. Here's the apex. And so the vessel that's going to be going over the anterior wall of the left ventricle is the left anterior descending artery. Now, if we look at the image on the right, here is the left ventricle with the papillary muscles. Here is the interventricular septum. And so which chamber is this? And I'm pointing.
Sure, so that'd be, I believe, right ventricle.
Correct. The interventricular septum is going to be between the right ventricle and the left ventricle. And so that would make this chamber over here, which?
Oh gosh, okay, so we're looking at
this is kind of a coronal oblique view. You have right lung over here, left lung over there.
So would that be the right atrium?
Yeah.
Or like the right atrial? Okay.
Yep, you have the right atrium and then the right atrial appendage coming up here. So we have a vessel that's going in between the right atrium and the right ventricle. Which one is that going to be?
So the RCA?
Yes, this is the right coronary artery. So we have calcifications in the RCA and the LAD, and there's a little bit of bulging here. Maybe it looks like it's more than 50% of the diameter of the vessel just beyond that. So we have coronary artery aneurysms. And so the question is, what does this patient have?
Sure. So most common cause, I think at least in the US, is just atherosclerosis for coronary artery aneurysms, which makes sense with the calcified plaque as well.
Okay. What other diseases can give you coronary artery aneurysms?
Sure. So you can have like Kawasaki in children. I think connective tissue diseases as well. That's what I would think of, sir.
Yeah, so Kawasaki's, and then Marfan is probably the one that most commonly will give you coronary artery aneurysms. So really, the answer to this question is, how old is this patient? So this patient is only 14 years old.
Oh, wow.
And so this is Kawasaki's disease. Now, if I told you that this patient was 64, it would be atherosclerosis. And so really, this is a scenario where if you were doing an oral board exam, you'd want to ask the examiner, how old is the patient? And then based on the answer, you would say, you know, in this 15-year-old, this is Kawasaki's disease. Or if they told you he was 75, you'd be like, this 75-year-old has atherosclerosis.
Yes,
okay.
thank you.
And so again, as a reminder, any of the inflammatory vasculitides, when they heal, they can heal with calcification. So not all vascular calcifications are atherosclerotic. It's the most common cause. Atherosclerosis is the most common cause of calcification, but is not the only cause.
Thank you.
Sir, we actually have several questions coming in.
Okay.
So on the last case, there was a question on, yes, so I believe on our like kind of radiology, right? On that case you just had up, is there a left ventricular apical aneurysm as well? So I think they're talking
Oh,
about
down here.
there.
Good question. I think in this case, I would just say that it's thin, and you know the apex can be thin like this. It's just part of the normal, you know, the range of normal. I think some clues that this is just part of the normal variation is that you have a very smooth tapering of the thickness of the LV wall as you get out towards the apex, as opposed to a more abrupt transition that you would get in this setting of an LV apical aneurysm. Sometimes it can be very difficult sometimes without cine imaging. If you had cine imaging, the aneurysm would be akinetic or dyskinetic, whereas normal thinning, you would see some contraction in that area.
Great. And while we're on this image, there's also a request for now kind of radiology left or screen right on this. If you could review just the anatomy one more time. So I think
Oh,
from
yeah, so,
yes, you got it.
So, you know, when you're looking at this coronal oblique image, you know, look at the lungs. And that's going to be, I think, one of your first clues. So we have the right lung and the right heart border. If you think about your chest x-ray, is the right atrium. The right ventricle is in the middle. So we don't see the right ventricular heart border anywhere on a frontal radiograph. And then you have the left ventricle that forms the, you know, the apex of the heart. And it's up against the left lung over here. So we have left ventricle with some very large papillary muscles, smaller trabeculations, interventricular septum, right ventricle. The right coronary artery goes in between the right atrium and the right ventricle.
Thank you. And we had one more, and it was the case before that one, actually, just regarding how to most confidently choose which cusp is the, as you call it, posterior or like non-coronary cusp. Is there a good way that you would use that if we aren't given a standard view?
Yeah, so hope, you know, if the image is a little zoomed out a little bit, you can use the sternum as your reference point for anterior. Now, in this case, we don't see the sternum, but we do see, you know, the medial aspect of the right upper lobe and left upper lobe. So we can kind of use that as our guide for what's anterior. Back here posteriorly, we can see maybe a little bit of the spine. So you use that as your guide. And we see then posteriorly pulmonary veins, left atrial appendage, and right ventricular outflow tract. So the left sinus is going to come out in between the left atrial appendage and the right ventricular outflow tract or pulmonary artery. Whereas the right coronary, right sinus of Valsalva is going to be directed towards the right interventricular groove, the groove in between the right atrial appendage. See how that right atrial appendage is right next to the right lung? So and then we see a little bit of the RVOT or infundibulum up there anteriorly. And the groove in between the right atrial appendage and the right ventricular outflow tract, that's the right interventricular groove. The right sinus is going to be directed towards that. And then the posterior or non-coronary sinus is going to be directed towards the interatrial septum. This is the superior sinus venosum, or the superior cavoatrial junction near that area. So hopefully that gives you a good explanation of how to orient yourself, what structures to look at and identify to help you figure out which sinus you're looking at.
Yeah, that was great. Thank you. And we have, sorry, one more question in this slew here. Any advice on telling positive remodeling and coronary artery aneurysm apart?
So in this coronary artery aneurysm, we really don't have any, there's no thrombus, it's all lumen, it's enhancing. Whereas in positive remodeling, the lumen is either going to be normal in caliber or it will be narrowed. Does that make sense?
Yes, thank you. And then now for the next case, we'll have Tucker from Loyola.
So there's another patient that presented with chest pain.
All right. So I think we're looking at similar anatomy to the prior. So I think that's the RCA. And it looks like there's an area of narrowing and then like post-stenotic dilatation maybe.
Yeah, so this is a 12-year-old patient, and we have a very large aneurysm right here, proximally, some smaller aneurysms distally, and there are stenoses proximally and in the middle portion of the RCA. And so what does this patient have?
I'm tempted to say Kawasaki's. And
okay,
okay.
You would be right. So in a 14-year-old coronary artery aneurysms, that's going to be Kawasaki's disease, okay? All right, and so now the next series of questions are all related to different types of congenital heart disease repairs, okay? So this is the first type of repair. This is a volume rendered image. Here on the left, we are looking at the heart from the front. And then on the right of your screen, we are looking at the back of the heart. So you have the ascending aorta right here. And then on the screen right, you see the descending thoracic aorta over here. First vessel, this is the brachiocephalic artery. In this case, it's a left brachiocephalic that comes off first. And we look at it from the back. Here is the left brachiocephalic artery. Okay, and this is the repair. This is the shunt right there.
Okay. So yeah.
I'll give you a few options. I'll give you 4 options, and you tell me which one it is.
Okay.
So is this a Potts shunt, a Waterston shunt, a Blaylock-Taussig shunt, or a Glenn shunt?
Okay, so I know Glenn is like SVC, and I think Blaylock-Taussig is. I think I would guess Blaylock-Taussig, but I'm not
You would be correct. So this is a Blalock-Taussig shunt. In this case, they have some synthetic graft that connects the subclavian artery to the pulmonary artery. This is an infant that was born with cyanotic congenital heart defect. I think tricuspid atresia, if I'm not mistaken. And so very early in life, they need to get blood somehow to the pulmonary circulation. Okay, and then we're ready for the next repair.
And the next and our last volunteer is going to be Adrian from University of Utah.
Okay.
Hi, it's nice to meet you. So it looks like we have a 3D reconstruction of the vasculature and heart. And then there's some type of, I don't know what the name of that is, but it looks like a flow dynamic imaging on the screen, right? So it looks like the left or the superior vena cava is connected to the pulmonary arteries, which are disconnected from the heart. And there's still an outflow tract, which it looks like is the aorta. So I think this is the Glenn shunt.
Yeah, exactly. So here they have surgically connected the superior vena cava to the pulmonary arteries. And in this case, this would be a bidirectional Glenn because they left the right and left pulmonary arteries in communication with each other. And then what about this shunt?
Okay. So it looks like, I think this was a hypoplastic left heart repair. I think that there's a common outflow tract, which I think was originally the Norwood procedure, coming out of probably a combined large ventricle. And then there's a Fontan procedure as well, which essentially is shunting blood. It's completely bypassing the right atrium, I believe, and going into the pulmonary vasculature. And then there would also be, which I don't think we can see, there's an ASD, or there should be an ASD as well.
Yeah, so this is, as you pointed out, this is a patient with hypoplastic left heart syndrome, and they've undergone all of the stages to basically reroute systemic venous return directly to the pulmonary arteries. So usually the first step is to create a systemic arterial to pulmonary arterial shunt. Nowadays, that's done with a Blalock-Taussig shunt or a BT shunt. And then when they're a little bit older, they'll do a Glenn, where they connect the superior vena cava to the pulmonary arteries. And then when they're even older, they will completely bypass the heart with the systemic venous return. So you have this total caval pulmonary connection, which more commonly referred to as a Fontan. And there are a couple different Fontan flavors that you will see. You might still see some of the original variation of the Fontan, where the IVC kind of goes through the right atrium into the right pulmonary artery, or to the left, and then the superior vena cava goes to the right pulmonary artery, completely separate from each other without any communication. You very rarely see those anymore. So the two broad categories of Fontans that you're going to be seeing are what they call intracardiac Fontans, where you use the right atrium as the connection between the inferior vena cava and the pulmonary arteries. You can use the entire right atrium. That's not done anymore because it just starts to grow and dilate and becomes a big bag that doesn't do anything. blood just stagnates and forms clots, like you can see in this patient. So they don't do that anymore. Nowadays, the surgeons that still perform an intracardiac Fontan, they would kind of more commonly referred to a lateral tunnel, where they would take a portion of the right atrium, the posterior wall of the right atrium, and create a tunnel or a conduit using the patient's own tissues to shunt IVC to pulmonary arteries. Or the other broad category of shunt is an extracardiac Fontan, where the shunt is made with consists of synthetic material. And I think this is probably a little bit more popular here in the US. And then I guess before we tackle that next case, I did briefly mention two other shunts, the Potts shunt and the Waterston shunt. Again, you don't see those very often, but the Waterston shunt is a connection between the ascending aorta and the right pulmonary artery. And then the Potts shunt is a connection between the descending aorta and the left pulmonary artery. There are variants of the Blaylock-Taussig shunt. It's just, instead of using the subclavian artery, you're using the aorta. You do not need to know why you would use one or the other. I think that, if you are going to get a question related to shunts or repairs, you're most likely going to see Blaylock-Taussig, Glenn, and Fontan. And then you might get a question about this repair. And so I think all of the volunteers have taken two questions. And so I'll pause. You think of the answer, or no, is this your second? I can't remember. Is this your second case?
I took two.
Okay.
So you can open it up to the to the general chat or whatever you'd like to do.
Okay.
Yeah, I think that's a good idea, sir. To give a couple seconds for people to try to guess on their own, and we'll let you work through them. Thank you.
Yeah. So you've all had a chance to look at these images for a little bit. And what's unusual about this case, so we're looking at the thoracic vasculature kind of from the top down. And the anterior chest wall is down at the bottom, and the spine is up here in the top. You can see the aortic arch, descending thoracic aorta over here. Here's a little bit of the left ventricle. Here is the right ventricle, pulmonary artery. And so what's unusual about the anatomy in this case is that the main pulmonary artery is in front of the ascending aorta, and you see the branch, the right and left pulmonary arteries branch over the top or over the anterior aspect of the aorta, which is not normal. And so this is a patient that was born with detransposition of the great arteries, and was fixed or repaired with arterial switch, a Jettine, and then the maneuver where they put the pulmonary arteries in front of the ascending aorta is called the LeConte maneuver. So you might see a question, some images that look like this, and they might ask you, what was done in this case. And so you'd want to look for arterial switch, Jettine, or LeConte maneuver. Okay. All right. So so I was a resident at Loyola a few years ago, back when we still had hot seats with real film, and I got this case as a first-year resident, and I got it as a third-year resident. And I should have learned after I took the case as a first-year resident, but I didn't remember it. But then after I saw the exact same case as a third-year resident, I kind of figured out how to take this kind of case in the future. And so when you're looking at this chest x-ray, everything looks normal, normal heart size, looks like the mediastinum is normal, normal vasculature, the lungs are clear, no pleural effusion, pneumothorax, no pneumonia. But it would be highly unusual to get a normal study on a board exam. So then you're like, okay, what am I missing? And it turns out, if you look very, very closely between the aortic arch and the left pulmonary artery, there's an abnormal contour. You can see a figure of 3 sign. This is a patient with coarctation. So then if you look very closely, there's a very subtle rib notching here bilaterally. So what I kind of tell the residents when I show them this case, and when I remind myself when I see something like this on a board exam, if the chest x-ray looks normal, make sure you're not missing a coarctation, okay? And so this is the MRA that was performed in this patient. You can see a very severe coarctation. It's a ductal coarctation, very large intercostal arteries, very large internal mammary arteries. Nowadays, they might be able to fix this with a stent, or they could do it open with a resection and then put a little graft in there to fix it. And then when you see aortic coarctation, it's important to think about bicuspid aortic valve. There's a very high association between bicuspid aortic valve and aortic coarctation. Okay, this is a 13-year-old who went in for a yearly physical, and the pediatrician heard a systolic murmur and referred first to an echo, and then after the echo, they got a cardiac MR. And so this is an MR physics question. And the question for all of you is, what are you seeing here in the bicuspid aortic valve? And then actually in the way they would probably structure it nowadays is, how would you improve the image quality, or what would you do to fix the error that you see in this image? And again, this is another bicuspid aortic valve, and this is a phase contrast or velocity encoded image. And you see an artifact there in the center of the bicuspid aortic valve. And what you are seeing is aliasing, because we selected a velocity encoding level that is too low. And so what you would do to get rid of this artifact would be to increase your velocity encoding. Let's say you initially set your VENC to 150. Given the amount of aliasing that you see in the center there, you would probably increase it to 250 or 300. So they might, give you a list of MRI parameters that might include the flip angle, the TR, the TE, the matrix, and the velocity encoding. And then they would ask you, which of these parameters would you adjust to correct the error that you are seeing? And the answer would be the VENC, okay?
Dr. Francois, on that one.
Yes.
Well, how do you know it's aliasing, or what is it about it that's not right?
So if you look in the center of the image, you see that it's very pixelated. It's very steppy, kind of like what you see in the lungs. Whereas if you go to a corrected image, you can see when you have no aliasing. It's a much smoother border around the area that has flow in it. You don't see, it does not look like the noise in the lungs. So as we kind of go back and forth between this aliased image and unaliased image. Do you appreciate the difference there?
Yeah, thank you.
Yeah. Now in this case, it's severe aliasing because I purposely, because I needed a case that showed it, and so I purposely set the vanc super low, much lower than I should, and so the entire flow in the valve was aliased. They would probably show you one that had a few pixels of aliasing in the center.
Oh, sir, and regarding the phase imaging, what plane are the images acquired in? We had that question in the chat.
Oh, yeah. So when you are, so to quantify the amount of flow through a vessel or through a valve, you want your plane to be orthogonal to the direction of flow. Now you can set up your flow acquisition to be in the same plane as flow, and you would be able to measure the velocities, but you would not be able to quantify the volume of flow through a region of interest. So if you want, so in this case, we are double oblique to the aortic valve, sort of a short axis view, if you will. So this is a pre-op chest x-ray in a, she's 47. She's going to be undergoing some orthopedic surgery procedure, and she had this pre-op chest x-ray. I'll let you all look at it for a little bit.
And actually, sir, we had one more question come in about the last case, whether it was showing regurgitation or stenosis at the valve.
Yeah, good question.
Yeah.
So we'll go into that a little bit later. I have a couple other cases that will go over regurgitation, stenosis. Now, in that particular case, I was only showing you a single image, and that single image was from systole. And if we measured the velocity there, we would have measured a velocity of 3 meters per second. And the normal velocity through the aorta can be up to 1.5 meters per second. So that would have been aortic stenosis. Based on that single image, you can't say anything about regurgitation. But I have some slides a little bit later that will go over that.
Thank you.
So this is an abnormal cardiac silhouette. The cardiac silhouette is enlarged. The apex of the heart is elevated. There is a right-sided aortic arch. This might look a little bit like a boot, sort of the moon boots from the 1970s and early 80s, maybe an UGG boot nowadays. So a boot-shaped heart is associated with tetralogy of Fallot. And so this is a patient who had uncorrected, previously unrecognized tetralogy of Fallot. And so we'll let these cardiac MR cine images play for a little bit while you all think about the 4 things that make up tetralogy of Fallot, the 4 abnormalities. And we'll go through each of those in this case. And so the 4 things that we're looking for that make up tetralogy of Fallot are right ventricular hypertrophy. And you can see that very nicely in the top row. And in the top row, middle 2 images, you can see the ventricular septal defect, in this case, a membranous ventricular septal defect. So that's the second abnormality. And then as you come up a little bit higher to the top right, and then in the second row, the left-handed image, you see an overriding aorta. And then the fourth abnormality is pulmonary stenosis, or in this case, pulmonary atresia. In the case of the patients who have pulmonary atresia, it's not unusual for them to present later in life because they had complete pulmonary atresia, they had to develop these large collaterals between the descending aorta and the pulmonary arteries to get blood flow out to the lungs. And now in this case, they're so large, they're massive, so massive aorta to pulmonary collateral arteries, or MAPCAs, that was enough. It was kind of like it's like a shunt, but in this case, that's how she was born, okay? So we have these very large MAPCAs, or collaterals, between the aorta and the pulmonary artery. And at this point, she would undergo repair. Okay, next case is a patient who presented with a cough. Now, you expect to have some of your cardiac imaging cases be chest X-rays. And we have a frontal radiograph on the left, lateral radiograph on the right. And I'll let you look at that for a little bit. And the abnormality on these images is a curvilinear density in the right lower lobe. Kind of comes from the center of the right lung, and you can kind of follow it back into the right atrium, or inferior vena cava. And this is a patient with scimitar syndrome. So in addition to this large curvilinear density, which is the anomalous pulmonary venous return, we have a small right lung. And then if you look at the hilum, the right hilum is abnormal. We do not see any normal pulmonary arteries. Look at the left hilum. This is what a normal hilum should look like. And if anything, this is a little generous, but you should be able to see pulmonary arteries, within the hilum. We do not see that on the right because the patient has pulmonary atresia as well. So in patients with scimitar syndrome, you have this anomalous pulmonary venous return in the right lung. You have right lung hypoplasia, and you have right pulmonary artery hypoplasia. Next case is a 34-year-old male. This is a 3-chamber view. We have the left atrium, left ventricle, right ventricle. And as you look closely at the interventricular septum, it's very, very hypertrophied. This is a patient with hypertrophic cardiomyopathy. And so, questions that might arise related to this would be, the diagnosis of hypertrophic cardiomyopathy. But I think other questions that they would ask would be related to the presence of left ventricular outflow tract obstruction. And then in this case, the patient has mitral regurgitation. So you see that black jet during systole going from the mitral valve leaflets into the left atrium. That's mitral regurgitation. And in this case, it's due to systolic anterior motion of the mitral valve leaflets. So they might ask you, why does this patient have mitral regurgitation? They might ask you, does this patient have left ventricular outflow tract obstruction? Something like that. And we have more examples of hypertrophic cardiomyopathy coming up to go over some of the other aspects of what you would look for in these cases. So this is a 40-year-old male. These are cine images. And as you look at the interventricular septum, you can see it flicker. And so that's what we call a septal bounce. And there's a few things in the differential diagnosis for a septal bounce. But one of the classic diagnoses that gives you a septal bounce that this patient has is, let you think about that for a little bit. So one of the primary diagnoses that we associate with a septal bounce is constrictive physiology. And if we look at the pericardium in the middle row, it is very, very thick. The normal pericardium should only be about 2 or 3 millimeters. And you can kind of see some normal thickness pericardium here inferiorly. Out here anteriorly, below the right ventricle, it's very, very thick. And so that's what this patient has. And one of the ways we diagnose this clinically is to do real-time cardiac MR. And that's what you're seeing here in this movie. These images were obtained in real time, and then we instruct the patient to take in a deep breath or perform a Valsalva maneuver that increases systemic venous return. When you increase systemic venous return, you get more blood coming into the right atrium and right ventricle. And because the thickened pericardium is constricting the right ventricle, you see flattening or bowing of the interventricular septum to the left. And so when this patient takes in a deep breath, you see flattening of the interventricular septum. When they breathe out, the interventricular septum is round, more normal. So intermittently, you can see that interventricular septum becomes flat. And if you look closely at when that is occurring, you can see that it is more pronounced when the patient breathes in. And we can also assess the pericardium with these myocardial tagging images. Normally, the tag lines should separate at the level of the pericardium because the visceral and parietal layers of the pericardium, they slip past each other. However, in patients with constrictive pericarditis, the visceral and parietal layers of the pericardium are adherent to each other. They cannot slip past each other. And so these tags do not break. And you can see that, if I show you these still images, the pericardium is out here. And this is what it looks like in diastole. Normally in systole, if you have normal pericardium, you will see a step off between the lines in the pericardial fat that are outside of the pericardium and the tag lines that are in the epicardial fat between the pericardium and the myocardium. However, in constrictive pericarditis, where you have tethering of the two layers of the pericardium, those tag lines do not break. Okay. Next case is a 78-year-old. This is actually presented with a stroke, and this was the chest X-ray that was obtained during admission. You can see the bypass clips. This would probably be the one situation where I would actually think it's important to mention the clips in your chest X-ray report. Most of the time, they're not important to describe, but in this particular case, it is. Because if you look at the left ventricular apex, that is not a normal contour. You can see this bulge out near the apex of the heart. Now you've got this mass next to the left heart border. It could be anything. It could be in the lung. It could be in the mediastinum. It could be in the pericardium. However, given the fact that this patient has had prior coronary artery bypass surgery, there's one other thing that you got to think about, and that's a left ventricular aneurysm. And so we did a cardiac MR, and we have some bright blood images here in the top row, left and middle, some coronal T1 weighted images, before contrast on top, after contrast on the bottom, and then some late gadolinium enhancement images down here on the bottom. And so you see this abnormal bulge or aneurysm near the LV apex, and inside of that aneurysm, you see a clot. And a couple things I would point out here on these images is the transmural infarct that you see in this aneurysm. So you have a transmural infarct, that's not going to get better. The thrombus inside of it is very, very dark. It does not enhance. On the T1 weighted images, before contrast, thrombus in the heart looks like thrombus in the brain. It's going to be, depending on the age of the thrombus, it could be really bright on the T1, or it could be iso-intense to blood, depending on the age of the thrombus. So anyhow, this is sort of relatively acute thrombus, so it's very, very bright on these pre-contrast T1 weighted images. You give some gadolinium, and it looks like it's dark, but if you actually measure the signal intensity, it's the same after contrast as it was before contrast. Okay, next case is a 35-year-old with chest pain. Again, I like to show this case to the residents because it's a reminder that you have to look at the heart in every single study that covers the chest. You cannot ignore it, even if it's not a dedicated cardiac CT or coronary CT, because you will find abnormalities in the heart that are going to make a difference in saving the patient's life. So if you look closely at the heart in this case, this is a non-gated study. This is a PE study. The timing of the contrast bolus is off a little bit, which is good because we now have some contrast in the left ventricle as well as the right ventricle. And most of the myocardium is enhancing, but there's a very large part of the myocardium that is not enhancing. So I hope all of you can see that. This very large area near the apex of the left ventricle that is not enhancing. That is a perfusion defect. This is a patient with a myocardial infarction. Now, a relatively young patient, 35 years old. It could be due to atherosclerosis, particularly if they have a history of familial hypercholesterolemia. But you would also want to consider vasospasm as a cause of an acute myocardial infarction or spontaneous coronary artery dissection. So there is a differential for acute myocardial infarction that goes beyond atherosclerosis, particularly in younger patients. And here's the cardiac MRI from this patient. You can see very hypokinetic, akinetic, anterior wall, anterior septum, true apex. It's not thickening, it's not squeezing. And then on the late gadolinium enhancement images, you can see a transmural infarct. And so question might be, is that going to get better at 6 months? No, that's not going to get better. In general, we use a threshold of 50% of the wall thickness to decide whether or not that segment is viable or not viable, decide whether or not that area is going to get better or not with revascularization. Another question that they might ask regarding a case like this, they might point to this little bright jet that you see during systole and ask you, what is that from? And so that little bright jet that you see coming from the mitral valve leaflets during systole when the mitral valve leaflets should be closed, that's mitral regurgitation. And you see, and it has brighter signal than the adjacent signal in the left atrium due to some dephasing of the spins. There's also a similar effect that gives you the brighter signal in coming out of the aortic valve. There's a little bit of turbulent flow coming out of this aortic valve.
Sir, with that case, there was a question in the chat. If you could See, would you call those, I think the hypoenhancing regions are along the LV wall, microvascular obstruction or occlusion there?
Yeah, exactly. So very nice pick up there. You see the black areas that are surrounded by the enhancement. That is due to microvascular obstruction. So we acquired these images about 10 or 12 minutes after we injected contrast. In these areas of microvascular obstruction, it is so obstructed due to necrosis, edema, hemorrhage, that the gadolinium doesn't have enough time to get to that territory to give you the enhancement. So it's just an indication that the infarct is really, really bad, very, very poor prognosis. The prognosis was already bad because it was transmural. It's just even worse because you see the microvascular obstruction. And that's usually due to a reperfusion injury. So, patient that presents with a ST elevation MI, they have to take them to the cath lab. They have to open up the affected vessel within 90 minutes. When you do that in a really big infarct, you get that big rush of oxygenated blood, and the oxygen in the blood actually causes this injury. You're not going to not open it up. It's just it's a consequence of opening it up after having a really, really big infarct. So here's the next case, a 14-year-old with heart failure. And we have a 3-chamber view on the left and a 4-chamber view on the right. And the question would be, what type of non-ischemic cardiomyopathy does this patient have? And so as you look closely at the left ventricle in particular, you also see it in the right ventricle, but mostly in the left, very, very trabeculated myocardium. Has a fishnet appearance to it. Very little compact myocardium. This is left ventricular non-compaction. And a ratio that is commonly used to try and decide if this is normal or abnormal is 2.3 to 1. I don't expect they would show you a subtle case that's on the border. If they are going to show you a case of non-compaction, it's going to be a very obvious case like this. You do not need to measure the ratio here. Okay, the next case is a 34-year-old male who has heart failure. This is a 4-chamber cine view. Anterior, posterior, here's the spine, here's the descending aorta, left atrium, left ventricle. They are relatively normal. And then you have humongous right atrium and right ventricle. And there's very few things that will give you this much right ventricular and right atrial enlargement. One of them is what this patient has, and that's Epstein's anomaly, where you have apical displacement of the septal leaflet of the tricuspid valve. The normal distance can be up to about 15 millimeters. And so if that septal, if the leaflet of the tricuspid valve is displaced more than 15, then you would want to consider, then that would be consistent with Epstein's anomaly. So you have atrialization of a large portion of the right ventricle. This is a 71-year-old who presented with a right bundle branch block. Relatively normal cine images. And these are the late gadolinium enhancement images. Just to remind everyone, normal myocardium will be nulled, so it'll be black, and abnormal myocardium will enhance. And so that'll be bright or white, like you can see here up at the base. We see some enhancement here in the septum. We see some enhancement here in the inferior wall, a little bit in the anterior wall as well. And so we have patchy mid-myocardial late gadolinium enhancement in a patient with right bundle branch block. And so the question could be, what would you do next? Would you do a left heart cath in the patient to look for coronary artery disease? Would you do a whole body CT scan to look for primary malignancy? Or would you do a CT of the chest to look for sarcoid? And the answer is, here's a zoomed in view showing the enhancement. So the correct answer would be you would do a CT of the chest to look for pulmonary sarcoidosis. And this is a very nice example, chest CT findings of pulmonary sarcoid, where you have these hyperdense mediastinal and hilar lymph nodes, and then you have perilymphatic nodules in the right lung, right next to the vessels and along the major fissure. So this is a patient with pulmonary sarcoidosis and cardiac sarcoidosis. Now, this patchy mid-myocardial enhancement is not indicative by itself that this is sarcoid. There is a differential. The two most common things that we see with this pattern of enhancement would be sarcoidosis and myocarditis. And really the best way to differentiate them is presentation. Usually when somebody has myocarditis, they usually present acutely, whereas patients with sarcoidosis, cardiac sarcoid, they frequently will present with heart block. And here's sort of a corollary case. This is a patient with ventricular tachycardia. And so we did a cardiac MR to look for any signs of scar or fibrosis. And this is a single late gadolinium enhancement image, short axis view. We have left ventricle, right ventricle, and there's this focal mid-myocardial area of enhancement in the inferior septum. Now, in this case, he presented with ventricular tachycardia. Again, this could be related to prior sarcoid. For whatever reason, I don't know the answer to this, but in my experience in patients with cardiac sarcoid, they typically will present with heart block as opposed to ventricular tachycardia, whereas patients who have mid-myocardial scar from prior myocarditis are more likely to present with ventricular arrhythmias. Now, if you were seeing this image without any history, you would say this could be from sarcoid or it could be myocarditis. You would look to see if they had a chest X-ray or chest CT. And if they didn't have any signs of pulmonary sarcoid, then you would assume that this is a scar related to some prior non-ischemic event, like myocarditis. You cannot tell what type of myocarditis this was due to. This could be from COVID. It could be from any other viral myocarditis. Next case is a 53-year-old who presented with heart failure. And let you look at the 4-chamber cine view here on the left and these 4 short axis views on the right for a little bit. And what's striking about these images is how hypertrophied the left ventricle is. In a test setting, they might put some calipers on the myocardium, on the LV myocardium. In this case, it would be maybe 16 or 17 millimeters in the septum as well as the lateral walls. We have concentric left ventricular hypertrophy. The right ventricle also looks a little thickened. So here's some static images to give you a sense of how thick the LV and RV are. Concentric left ventricular hypertrophy. And then here are the accompanying late gadolinium enhancement images. And these are not very pretty images. And that's usually the first clue to the diagnosis. You get a call from the technologist saying, can you come take a look? I can't get the late gadolinium enhancement images to look pretty. I cannot get the myocardium to null. I think there's something wrong. And you're like, no, I don't need to come to the scanner. I know what the answer is, and you're going to be right most of the time. The patient has what this patient has. We'll get to that in just a little bit. But first, describe the findings. What we see is, again, very granular, noisy looking myocardium. But if you look closely, there's sort of this diffuse enhancement all the way around, kind of from subendocardial to subepicardial. There's even some enhancement of the right ventricle. And so there's really, in my experience, just one thing that will do this, and that's cardiac amyloidosis. So they might start asking you questions about T1 mapping. I don't think it's fair in all honesty, because it's not done everywhere. But T1 mapping, where you actually measure or quantify the T1 values of the myocardium, in cardiac amyloidosis, it's probably the one of the few scenarios where T1 mapping actually can be helpful in an individual patient, because the amyloid has such a high native T1 value. And so the T1 values are much, much higher than you would see in normal myocardium. And I'm not going to say anything more, because I don't think they should ask you that kind of a question. All right, next case is a 7-month-old. And this is an axial bright blood image. This is a 2-chamber view. This is the left ventricle, left atrium, left ventricle, right atrium. And you see a humongous mass arising from the left ventricle. And so you can think about what that might be. And so when you're characterizing masses, really the question, the first thing that you need to address is, where is it located? Is it in the muscle? Is it in the lumen, inside one of the chambers, so intracavitary? Is it along the epicardial surface, or is it on a valve? Because once you've figured that out, your differential becomes much smaller than it would be if you just kind of consider all masses equally. And so this mass, it's quite exophytic, but it's primarily arising from the myocardium. And in patients that are this young, there's really just a couple things in the differential, particularly for intramyocardial masses. The most common are going to be rhabdomyomas and fibromas. But really the answer is going to be made when they show you the MRI of the brain. And so, is this a rhabdomyoma or is it a fibroma? And the answer is rhabdomyoma in a patient who has tuberous sclerosis. And so you can see the typical features of tuberous sclerosis here in the brain, and these patients often have rhabdomyomas. The next case is a patient with bacteremia.
Sorry, sir, can I ask you a question back about the amyloidosis case? If we weren't given pictures of like late gadolinium enhancement, or if there was no late gadolinium enhancement, Is there a way to tell it apart from hypertrophic cardiomyopathy?
Only if you do T1 mapping. And then, so if you did T1 mapping without contrast, the amyloidosis is going to be much higher than hypertrophic cardiomyopathy. So just to give you some examples of numbers, normal myocardium is about 950. In hypertrophic cardiomyopathy, you might see values between 1,050 and 1,100, whereas in amyloidosis, it's going to be around 1,200, for example, so much higher.
Thank you. And then just for purposes of respecting your time and others, I know we've gone for almost 2 hours now. Usually everyone wants to keep going as long as you have time, but we don't want to make you feel like you need to stay longer. I just want to ask.
Yeah, well, we can go. Yeah, we can go maybe 5 more minutes.
Okay, sounds great. Thank you.
Okay, so this is a patient who presented with bacteremia. And you can see this globular mass on the mitral valve leaflets. This is in a patient with bacteremia. This is endocarditis. Could it be a papillary fibroelastoma? I suppose, but you would then have to presume that this is infected because the patient has bacteremia. And this would be a very, very large papillary fibroelastoma. And on the reformatted images, you can actually see a perivalvular abscess arising from the anterior mitral annulus. So once you see these images here, really the differential is endocarditis, and that's it. So this is a 26-year-old who presented with palpitations. And this is a patient who had, like when you do the quantification, the right ventricle is enlarged and the right ventricular ejection fraction is low. And if you look closely here near the right ventricular outflow tract, there is an area of right ventricle that is dyskinetic or bulging out. This is where it is on the short axis view. This part of the right ventricular outflow tract, it is not squeezing in, it's not coming in, it is bulging out, so it's dyskinetic. So this is a patient with arrhythmogenic right ventricular cardiomyopathy. And so about 10 years ago, they revised the criteria that we use to establish the diagnosis of arrhythmogenic right ventricular cardiomyopathy. And some of those criteria are based on MR, and it's primarily the size of the right ventricle and how well it's functioning. So we're looking for areas of akinesis or dyskinesis, and then we are looking at the size, is it big, and then the systolic function, is it low? Interestingly, fat is no longer a part of the diagnostic criteria for arrhythmogenic right ventricular cardiomyopathy. Now, this is a patient who presented with acute chest pain, went to the cath lab, had normal coronary arteries. So we then did a cardiac MR. We have late gadolinium enhancement images on the left. We have T2 weighted images on the right. On the T2 weighted images, you can see patchy, bright signal in the myocardium consistent with edema. So we have myocardial edema here in the anterior wall and inferior wall. And then we have patchy late gadolinium enhancement in those same areas. And so really, in this case, the differential is also very limited. It's really just myocarditis. Some people have described slightly elevated T2 signal in cardiac sarcoid when you have active inflammation. In my experience, it's not this extensive. I guess theoretically it could happen, but the most likely diagnosis given these images is myocarditis. And then the other clue is the clinical history. And somebody who presents with acute chest pain, elevated troponins, clean coronary arteries, this is acute myocarditis. And again, you can't tell what virus or organism this is due to. This could be COVID. It could be any other virus that gives you myocarditis. This is a 57-year-old with a murmur. And this is another patient with a bicuspid aortic valve. Now, in this case, you can actually see the velocity time curve. The peak velocity is almost 4 meters per second. And you can see that the only signal that we see through the valve is during systole. It's forward, black. We do not see any backward or white signal during diastole to indicate aortic regurgitation. So this is a patient with a bicuspid aortic valve, aortic stenosis, peak velocity of 3.8 meters per second. No aortic regurgitation. Here's another patient with a murmur. And these are Cine bright blood images, 3-chamber view, showing the dephasing signal from the stenosis in the proximal ascending aorta. And then during diastole, we see this dark jet coming into the left ventricular outflow tract. That is the aortic regurgitation jet. And so if we were to do, when we did flow quantification through the aortic valve and did that same analysis, you can see that during systole, we have flow above the curve. So that's positive flow. And then during diastole, we have regurgitant flow. And so we can calculate the amount of regurgitation just by quantifying the amount of flow during diastole. And then we typically will report this as a fraction of the forward flow, giving you a regurgitant fraction. And using that regurgitant fraction, you can then grade the severity of aortic stenosis. I mean, of aortic regurgitation. So this will be our last case that I'll show you. This is a PE study, and we had a very slow heart rate. So we happened to catch the tricuspid valve very, very nicely. And you can see this big lobular glob on the tricuspid valve. Differential would be a papillary fibroelastoma, a vegetation, or potentially thrombus. We told the ordering provider to check for bacteremia. The patient was bacteremic. This patient had endocarditis. Okay. So I don't know, are there any other questions that people have before we hang up here?
Thank you. Yeah, we got two here recently. So one is, do we need to know the thresholds for FFR, do you think, for the core?
Good question. I don't think so. If so, just to remind everyone, so CT fractional flow reserve, if the value comes back less than 0.7, that would be considered hemodynamically significant. Personally, I think that's still relatively new it's only been out for maybe 2 or 3 years, and a lot of places are not doing it. So I think that would be kind of unfair, in my opinion. Kind of like native T1 mapping is kind of unfair. But
Thank you. And then we had a couple questions also on back to the most recent phase contrast, I think, Hart. So the question is, how did we know that the VANC, on the VANC sequence, that the black signal within the valve was stenosis and not regurgitation? And then someone else also asked if you could just review the anatomy on that image.
Oh, sure. So so depending on the scanner and depending on how you set up your scan, forward flow could be black, forward flow could be white. And for whatever reason, there's no agreement amongst the manufacturers as to how to assign the grayscale values for forward and backward. And so the clue that this is forward flow is that that it's systole is that the valve is opening. And so the valve has to be open during systole. It does not have to be open during diastole. It shouldn't be open during diastole. And so the fact that we are only seeing black signal is the clue, is one clue that this is happening during systole. The other clues to look for would be the size of the aortic valve. So during systole, it's going to be larger than diastole. Now in these grayscale images, the anatomy can be difficult to identify, but here's the chest wall, right lung. This is the main pulmonary artery, aorta. There's probably left atrium over here, maybe right atrium over there, descending thoracic aorta over there. I have no idea what's over there. Liver is down here.
Thank you. I think those were the last few questions I was seeing here. And mostly a lot of people saying thank you and excellent cases. So we certainly all want to echo that, those responses. So.
Yeah. All right. Well, thank you very much. And best of luck with the rest of your studies and on your exam.
Thanks, Dr. Francois.
Thank you.
Yeah, thank you.
We appreciate it. This is
Bye.
great.
You're welcome. Bye.